Hello and welcome to this afternoon's Planning Skills series session, which is on health in all policies and health impact assessments. My name's Irene Beautyman. I am the Planning for Place lead at the Improvement Service, and many of you on the call will know me as having worked for a number of years now on that joined up ambition that we have within planning and within public health around the importance of the places where we live, work and play, and how they enable our well-being. Our session today really gets to grips with that, gets into the very detailed aspects of what the planning system, local development plans and so on can actually be doing to progress that within our sort of day-to-day work. So what we shall be covering today is we will be looking through both health in all policies and local development plans as an opportunity for health impact assessments. We have a range of speakers introducing planning and health. We will then go into more detail on health in all policies and some practical applications of that. And after that, there'll be an opportunity for questions and discussion. Then we'll look more specifically at health impact assessments, and again, their practical use both in Wales and a little bit about what is happening in Scotland as well. More opportunities for questions and discussions around that, and finish off with a chat about what resources and support are available for anybody looking to undertake a health impact assessment. So I'm going to pass over to my colleague Trevor Moffat, who is going to give us a little bit of our housekeeping and introduce the initial questions that we have around the Menti questions. There will be Menti questions as well as there being an opportunity to pop questions into the chat. Can I pass over to you, Trevor?
Okay, thanks, Irene. I've just got a few of the learning outcomes on the screen today, as Irene's just touched upon as well. Just to let you know, we will be sharing all the slides at the end of the session, along with a recording of the session, so that just be aware you are being recorded if you do come in at any point. And I'll next pass over to Meadhbh Maguire from Highland Council, and I'll just let Meadhbh come onto your screen as well. If you want to share your slides, and I'll just make them live for everyone else.
Can I just come in very quickly there just to say we've got such a mix, we've got a fantastic mix here today, which has come across there obviously, that it is both planners and people coming from a public health background. So Meadhbh has very kindly agreed to come along and give that kind of planning context. It's not, although Meadhbh works at Highland Council, it's not anything representative of what Highland Council are doing. It's that broader understanding of how the planning system is working at the moment to be able to take account of place and specifically to take account of a health in all policies approach and health impact assessments as well. So in that context, that will give us the planning background and context before we go on and get into the meat of health in all policies and HIA. So Meadhbh, over to you.
I'll just make myself and Irene disappear.
All yours, Meadhbh. Great, thank you. So yes, I thought I would commence today firstly by looking through some of these origins of planning and health. Many of us who have went through planning schools and planning education will probably recall a lot of this as to where the origins of planning actually came from. And those of us who did that will potentially recall that the Industrial Revolution is hailed as the point at which rapid urbanization, and particularly in urban areas, created a series of issues, often overcrowding and polluted, unsanitary living conditions. So we were dealing with open sewers, outbreaks of waterborne diseases, and a lot of these crises really sort of forced government intervention. And a lot of the things that came off the back of that were sort of generally seen as the starting point of modern planning, although they weren't called planning per se. But they certainly laid the foundations. So we saw some particular Public Health Acts, which actually were the earliest points of this. So in 1848, we saw the Public Health Act, which created the authority's ability to regulate water and drainage and waste removal. In 1875, we essentially saw the first form of building standards in the UK, which introduced minimum street widths and compulsory drainage systems. And this is formally the moment at which a lot of evidence would point to as the starting point of health in the built environment, and in which it became embedded. So we then started to see early planning movements, Ebenezer Howard's Garden City movement, for example, and also the City Beautiful and the Parks movement, which is more in the USA, but also in the UK, which promoted a lot of access to green space, to clean air, walkability, all intended to counteract the physical and mental health impacts of dense industrial cities. We then saw the formation of what we would now recognise as the modern formal statutory planning system that we use today. So the Housing and Town Planning Act in 1909 started the sort of plan-led system of housing, preventing poor quality speculative housing. But then also more formally in 1947, the post-war Town and Country Planning Act, which still forms the basis of what we use today. So very much focused on post-war slum clearance, the formation of new towns, and increasingly the separation of incompatible uses. So I suppose you could summarise by saying that town planning actually originated as a public health response to dangerous living conditions of the Industrial Revolution, developed through public health acts and housing reforms, and then finally evolving into that statutory planning system that we know today. So Scotland, like the rest of the UK, operated on this basis of a planning system of public leadership, community welfare, and rebuilding urban Scotland. And local government at that time had particularly strong powers, sweeping, you could say, development control powers. It was foreseen at that time that private market-led development would comprise a very small balance of the overall share of what would come through the planning system. And as we now evolve into the modern era, that changed quite significantly. So I suppose by the 1970s, changes in perceived health problems were apparent. Much of the infectious disease outbreaks were becoming increasingly distant, increasingly seen or perceived as solved. We now have universal clean water and sewage. We have vaccination programs, much of the slum clearance and better housing that's been achieved, reducing that overcrowding. And I suppose increasingly then with these public health victories, in the public perception, and politicians and planners increasingly saw health as handled by the NHS rather than by the built environment. And this has opened a lot of space for planning for other priorities, especially economic ones after this point in time. So planning's economic remit expanded. Although we still take account of health, the national priority was economic post-war rebuilding. And although health, as I said, was still a background concern, planning was sort of recast at this point as an instrument of economic modernisation rather than of public health. So we started at this point seeing the rise of private sector urban regeneration. We saw the urban development corporations, and notably things like the Clyde waterfront and others, which largely imported that London Docklands model. And this largely shifted regeneration powers from the councils to the market-oriented agencies. So this became the basis at which take us into the neoliberal economic policy that we then saw from the late 1970s, which had significant implications for planning in practice. So public-led planning design and intervention was reduced, deregulated, and there was an emphasis at that point onwards on competitiveness and growth and inward investment, and particularly in private sector-led development. So this firmly moved planning's centre of gravity towards economic development, and given the prolonged period in which this restructuring occurred, it was largely cemented over that period of the 80s. So in practice, this meant, you could say, that health was considered a byproduct of prosperity, but that prosperity itself was led through economic priorities, or alternatively, health was something handled by the NHS and not by spatial planning. There was also at the same time a professional separation, you could say, between planning and public health, even from an administrative view. So public health moved into medical structures of the NHS and planning remained in local government. But became more focused on land supply and development management. So by the 1980s, planning began to show signs of strain. Although it was designed that private sector-led development would be a minority of the caseload within the planning system, by the 1980s, that was obviously not happening any longer under a market-led system. So we became increasingly under attack as a profession as being slow, bureaucratic, and anti-development. We were essentially instructed to enable development rather than regulate it. And the way in which this could be evidenced that we were doing the planning profession justice was that we were delivering economic outputs, jobs, investment, and land supply, which became almost performance indicators of the planning system. And health outcomes were not measured in this way as directly related to planning, so they did fade somewhat from view. Many of the new challenges that became apparent, though, from this point started to overshadow health, such as housing shortage, car-based transportation planning, retail expansion, and also the competitiveness of regions, even within the same countries, and then also urban decline and regeneration. So much of the strong evidence base that we have on walkability, air quality, inequality, obesity, mental health, and how that was actually directly related to the built environment around people only became apparent to planners from the start of the sort of 1990s. Before that, policymakers just simply didn't see lifestyle diseases, environmental health impacts, or social determinants of health as planning issues. So the evidence suggests that, certainly from transition and from devolution, we now have control over planning policy, but Scotland inherited a market-led framework as well as, so we now have this control over planning policy, but the market-led framework underneath that is largely intact. So despite having a large wave of regeneration in the early 2000s, the post-2008 financial crisis did start to introduce some significant effects. It has exacerbated existing resource constraints, which restricts local authorities' ability to lead development directly. It also reinforces the reliance that was already there on private developers to actually build the built environment to a large extent. This can make public expenditure increasingly difficult to justify and difficult to long-term plan for. And when you're trying to build anything considerable at scale and do a real sense of a public sector-led regeneration and embed health from the design, the ability for local authorities to do that consistently at scale is significantly hampered by that. So post NPF4, we now, since February 2023, have a new national planning framework, and it's an ambitious national planning framework. It does attempt to reintroduce and embed social, environmental, and well-being-led planning principles. But these reforms, it must be remembered, operate on top of a private-led delivery structure. So even with these progressive policy aims, the ability of the public sector to lead spatial change is structurally limited. And then Scotland therefore continues to operate a system where policy is socially oriented, but delivery is predominantly private sector led. So how can health return more firmly into planning in Scotland? So in the early origins of planning, the state directly built, directly controlled, and directly shaped the urban environment. But today, by contrast, most development is private sector delivered, and local authorities act more as regulators, enablers, and strategic coordinators. And because of this, the tools for embedding health today within the planning system will look different than they did in the 19th or the early 20th century. In the origins, health outcomes were delivered through direct public works, but today we rely on policy frameworks, guidance, and policies that will actually shape those private proposals. In the origins, the state delivered health outcomes directly, but today the state has to deliver health outcomes indirectly through regulation, through policy, through incentives, and justifying this through formal evidence gathering and evidence basis, while the private sector builds much of the physical environment. Now, when we take this to local development plans at the moment, in Scotland at the moment, all local authorities and the 2 national park authorities are currently producing their new style local development plans. There's a very important window of opportunity, therefore, that the next policies that are used to decide development and to decide planning policy are actually embedded with NPF4, that health policies can be embedded in those plans so that when development management uses those policies, they can shape health through the development management process using strong, robust policies within the plan. The key takeaways from my presentation as an overview before some of the other speakers that we'll be learning from today is that both planning and public health have been on a considerable journey from those origins that we mustn't lose sight of. And while both were once strongly linked, this existed in a different public sector-led era. So strengthening health and planning in the present day requires developing mechanisms that will respond to the current public health issues that we face in Scotland. And they also will require grounded evidence of that area and how the built environment, if developed in a different way, could help those particular public health issues. And they also need to be mechanisms that will operate within our current economic and our political reality. My conclusion is that the purpose of planning is to manage development and the long-term use in the long-term public interest. And I think public health needs better embedded within planners' understanding of public interest. And this is going to be an intentional process to bring these 2 fields back together. Changing that culture and that practice will take time, and it will require stronger ongoing cross-sector working. I've also included a link to one of the reports that I've been very proud to work on alongside Public Health Scotland and Nesta, which sets out some recommendations for how the Scottish planning system could embed health, particularly through stronger collaboration between NHS boards and local planning authorities. Thank you.
Okay, thank you very much. And I'll just briefly introduce my colleague Michelle Gillies, who is also on the screen. I'm actually going to speak to this section of the programme, and Michelle is going to come back later on and talk about some of the resources that we've got within that we're working on to try and help this kind of work within Public Health Scotland. So I'm going to say a little bit about health and about health in all policies. If I could have the next slide, please, Trevor. So you're probably all aware that Scotland actually has a really dismal health record compared to other similar countries. We've got the lowest life expectancy in the whole of the UK, and it's much lower than other Western countries, much lower than we would expect really for our level of wealth in Scotland. And what we've seen since the austerity policies were brought in the early 2010s, we've seen that health life expectancy stopped improving, and inequalities have actually got worse in that time. And in some groups of people, life expectancy has actually reduced since then. So we've really got quite poor health overall. If I could have the next slide, please. And on top of that, we've got very, very significant health inequalities between people who live in the most deprived communities in Scotland and people who live in the least deprived communities in Scotland. And those health inequalities we define them as inequalities that are systematic, that are avoidable or unfair. And those are driven by inequalities in income, wealth and power. So the things that make the biggest difference to people's health and health inequalities is the socioeconomic status. So those economic determinants that Maeve and Irene were talking about are important, but it's also really more important how they're distributed among people, and at the moment they're not distributed in a fair way. And that impacts on many areas of life. If I could have the next slide, please. So Maeve mentioned how planning and health diverged, and health came to be seen as a medical thing that sat within the NHS. But what those of us who work in public health know only too well is that actually healthcare services they're only a small part of what determines the health of people in Scotland today. We know that health-related behaviours, physical activity, substance use, what you eat are also an important part. But actually, what makes a really big part of people's health is the places that we live in and people's social and economic environments. And we call these the building blocks of health. They include the local economy, they include social connections, they include the types of employment people have, the built environment, the natural environment, kind of work, the kind of transport, kind of housing. And all of those things are things that the planning system has a very large impact on. If I could have the next slide, please. And so that is the reason for a health in all policies approach. And I should say the health in all policies approach doesn't just apply to planning, it can apply to any sector. And the rationale for it is these building blocks of health, because we know that the interventions that target individuals, try to get individuals to change their behaviour, or that only look at healthcare services are not enough. If we want to improve the dismal health of Scotland's population, that needs planned and systematic action in all of the policies that affect those building blocks of health. And planning policy is one of the really major ones because it affects so many of those building blocks. If I could have the next slide, please. And so that's very much recognised in the Population Health Framework, which Scottish Government published towards the end of last year. And the Population Health Framework recognises the importance of good physical and mental health for all of us. It's not just a sort of niche health thing that only matters to healthcare and to public health people. It's something that really has a big impact on the economy and on our public services. We really rely on having a healthy population to support all of those other sectors. So it's really fundamental to progress among everything that's in the National Performance Framework. And so that was why the Scottish Government brought out the Population Health Framework. If I could have the next slide, please. And this is the framework. This slide is a little bit busy, but basically what the Population Health Framework does is it sets out the framework showing that we need to tackle all of these different things that affect health, the social and economic environment, places and communities, as well as healthy living and also health care. But all of those are underpinned by what is called the prevention focus system. And health in all policies is one of the actions within the prevention focus system by which we are going to tackle all of those pillars of health. If I could have the next slide, please. So what is health in all policies? So health in all policies, it's an approach to public policy making across sectors that takes what we call a sector first approach. And that means that we consider a specific policy or a policy area, including planning, and we take into account the range of ways in which that specific policy or policy area might affect on health and on different populations, and therefore on health inequalities. And the aim is to enhance positive impacts, but also to reduce negative impacts. If I could have the next slide, please. And it's very much about working in collaboration. So Meadhbh talked about how in the early days, planning was very much about health. There was a lot of collaboration there. And I think over time, we have lost that to some extent. And I see that really developing a lot more strongly now. But health in all policies is a way of working in collaboration across policies. It considers how decisions might affect health. And I think it's really important to say that health in all policies, like I say, it takes a sector first approach. So it's not looking at just one health issue at a time. It's taking a holistic overview of how a particular policy or a sector might affect a range of different determinants of health. It's not about health kind of taking over. It's about working in collaboration and trying to get the best overall outcome for everyone. But it does recognise that everyone and all sectors have a role to play in creating the conditions that are essential for good health of people in Scotland. So, and it's really to describe what I mean by the sector first approach. So very often in public health, what we do is we start off with a public health problem like physical inactivity or even a condition like diabetes. and we try and understand and we try and get lots of different people to come to our table to help solve that one public health issue. And Health in All Policies takes almost the opposite approach. It starts with a sector or a particular policy, and it understands the range of ways in which that sector might affect health. So something like spatial planning affects health in multiple different ways. It affects the quality of housing, the kinds of transport patterns, and therefore how active people are. It affects our access, our exposure to different types of food, to different types of environments. It affects green space. I could go on for a long time about all of the different ways in which spatial planning can affect health. And the importance of a Health in All Policies approach is that it takes account of all of those and tries to get the best overall outcome. Otherwise, you might get lots of different individual public health colleagues all wanting to work with you on different things, working separately on physical activity or quality of housing or poverty and access to employment, for example. So the point of the Health in All Policies approach is that it takes that holistic overview of all of the impacts of a sector. So the next thing I was going to move on to say a little bit about is within PHS, we've been doing some work to develop what we're calling a position statement on Health in All Policies that tries to explain that approach to Health in All Policies that we're trying to promote and has some practical processes and tools that you could use to adopt Health in All Policies in practice. And when the slides come back up, there will hopefully be a slide that shows what that position statement looks like. It will have two papers, one setting out the background and rationale, which is basically just the things that I've been talking about just now, and another paper that will have, we're calling it the implementation guide, that will have a bit more on the processes and tools that we might use in a Health in All Policies approach. So within our Health in All Policies statement, we have the implementation guide that has a few different approaches to Health in All Policies that include things like the Place Standard tool, which I'm sure many people on this call, probably all of you, are very familiar with. Health impact assessment, which we're going to say a little bit about later on in this session, and also other impact assessments. Incorporating health in other impact assessment is another really valuable way to take a Health in All Policies approach in practice. If I could have the next slide, I'll just go through these fairly quickly. So when we're thinking about the local development plan, I'm sure you're all familiar with this process through which all local development plans have to go through. And as Maeve says, it's a kind of once in 10 years opportunity to try and make sure that these do provide the framework that can create the best health and well-being and lower inequalities for people in all of those communities. So if I could have the next slide, please. So we're trying to think through how you might take a Health in All Policies approach and which processes and tools you might use at different parts of that process. And I should say that nobody's expecting that you're going to do all of these at all of these steps. It is just some ideas about how you might embed health within consideration of the LDP at different parts of the process. So if we start with the evidence report, alongside lots of other forms of evidence, I think it's really useful to include some public health data and other kinds of evidence on inequalities, socioeconomic and other health determinants, and the place and wellbeing outcome indicators are a really good way to help do that. You might also use the Place Standard tool for early engagement and to provide place-based evidence of how people experience communities and ask sort of local partners what are the priorities that the LDP might want to address. And I'm sure you'll all be doing that anyway. If I could have the next slide, please. And then at the proposed plan stage, that is the stage at which you might consider doing a health impact assessment. And we'll hear a bit more about that later on. But that can be done on the draft plan, either looking at the sort of overall direction of the plan or at very specific policies that are most relevant to health and well-being. And the aim of a health impact assessment is to highlight the unintended consequences for health and for inequalities in order to tweak those to get better health outcomes. And again, you might also potentially use the place standard tool to test some spatial options and inform site appraisal and support engagement. If I could have the next slide, please. And then finally, at adoption and delivery, if you've used health impact assessment, it will have made some recommendations. So hopefully they should be embedded into the final plan, but it can also inform monitoring of the actions and tracking of health and health equity outcomes that arise once the LDP is implemented. And the place standard tool can be used to follow up and inform future evidence reports for the next 10 years. So all of this is a cycle. And I should stress that it's not expected that you do all of these things at all these different stages, but it's just to illustrate that different tools can be used at different stages and provide different kinds of evidence. And it is about using different kinds of health evidence to embed that consideration into the LDP process. So I think that was my last slide. So I'm going to finish and pass back to Irene.
Yeah, thank you very much. Thanks for having me today. It's going to be short and sweet, very brief, just to take you through how we have sought to embed the health and all policies approach into our proposed plan. So as a little bit of context, Midlothian is the fastest growing local authority in Scotland. And with that rapid population growth comes a number of challenges, but one of those being the increasing pressure upon health and social care services, which in turn is widening the health and social inequalities of the authority. In our proposed plan, the wording that we've chosen to use isn't just health, we've gone for health and well-being. We wanted to recognise the direct and indirect impacts that the built environment can have on health in the round, not just our physical health, but including our mental health, for example. And many of us in the room will be very aware about the complexities which arise when trying to negotiate developer contributions towards physical health and social care infrastructure. A challenge that is once again exacerbated by the rapidly increasing population. And seeking those financial contributions is important, but what we're trying to do in the proposed plan is to seek to embed the building blocks of health and well-being, like Margaret mentioned in her slides just now, to try and go a bit further than just seeking this contribution towards a physical building for a health service, but also recognising that the places that we are creating to live, work, learn and play in, and those connections between those places are a key part of the wider environmental influences on health and well-being at both individual and community levels. So as such, like the creation of these places, which by creating these places that nurture health and well-being, that's an integral value of our LDP. So in terms of what that will look like, we hope that's going to look like on paper. We've incorporated health and well-being as a core strategic value in our LDP, and that's set out in the spatial strategy. And it's included as a strategic policy. I think it's the first policy in the proposed plan right away, health and well-being. We also have key policy connections through the plan, through policies such as quality of place and design, open space and play, hot food takeaways, housing, as well as incorporating appropriate references to health and well-being throughout the plan in general. A colleague of mine really doesn't like the term golden thread, but it's that type of thing, weaving health through all the time, not feeling like you're repeating yourself constantly, but just these little nuggets of pulling it all together and linking health throughout everything. So to do that, it goes back to way before the evidence report stage where we worked closely with NHS Lothian Public Health team and Public Health Scotland. I'm continuing to do that now, and they've been so helpful in getting us to this stage, and they've been reviewing iterations of our policy and our plan as things have gone along. So it's definitely a recommendation of ours to make those connections if you haven't already done so, or to not feel as if it's too late. Say you're through the evidence report stage and you're wanting to find out more about what Margaret has been speaking about. Just reach out to your local public health partners, and I'm sure they'll be pleased to help you there. We haven't carried out an HiA, and we weren't intending to, although that's something we would have considered had we all had the available time and resources, those two magical things. But we've prioritised focusing on carrying out the statutory assessments. But our integrated impact assessment was also prepared in conjunction with NHS Lothian. So we knew that that particular statutory assessment had already been, the template for that had already been written with a health lens on. So that was reassuring from a health and policies point of view, but also we involved the health partners in the IIA workshop and the IIA report writing stages. And finally, we strengthened the wording in our strategic environmental assessment as well, along with the wording around health and wellbeing in the SAA objectives, to try to reflect the health and all policies approach that we were taking with our proposed plan. So that's it. A quick fly through of what we've been doing.
So good afternoon, everyone. My name is Helen Hassel. I'm a Health Improvement Manager at Public Health Scotland, and I'm delighted to be here this afternoon and talking about health impact assessment to everybody. So to start off, just a brief overview about what health impact assessment is, or HiA as we often refer to it. It's effectively a process to judge the potential impacts of a policy on the health of the population, and we look at that quite broadly in reference to the building blocks of health that Margaret outlined earlier, and importantly is the distribution of those impacts within the population and whether those are equal or not. And it's very much a flexible process. It's impartial, so not defined by views from just one or two people, but kind of keen to get that broader perspective of views across the process. And it's also proportionate, and that kind of links back to some of the comments made already, which relate to time and resources available, any particular compliance requirements, and also the scale and scope importance in relation to health of that. And as we sort of outlined, it's just one of the approaches or tools that can be used to support health and health policies. And effectively, the aim of the process is to identify actions and recommendations which look at maximising positive health and wellbeing impacts, minimising or mitigating any negative ones, and reducing health inequalities. And this slide just outlines some of the guiding principles that are outlined for health impact assessment, which have been pulled together by the World Health Organization and the International Association for Impact Assessment. And they cover a comprehensive approach to health, which is really kind of taking that holistic approach that we've kind of been talking about, recognising that health is a lot more than just the NHS and healthcare, ill health. It's about health and well-being and people having the ability to kind of live their lives and be able to do what they want to do as part of that. There's sustainability, and that references to looking at both short-term and long-term impacts and how they will impact the climate going forward and hopefully contribute towards meeting UN sustainability goals. And then we have participation, which is a really, really key important aspect of health impact assessment, and making sure that the people that are affected by any plans or policies have an opportunity to sort of feed into that process as well and share their lived experience. We then have ethical use of evidence, and that's just about making sure that it's an evidence-based process and is the relevant data and information being gathered for that. And then finally, equity and equality is a key thread, and that's just really around making sure that, as well as looking at health more generally, we're considering the distribution of those potential impacts and what that might mean for health inequalities. So why use HiA? As we've kind of been talking about, we know that actually there's a huge amount of different policies and plans which can impact upon health. It's not just about the NHS and our what we do within the health sector, but many sectors across local government and beyond all have differing impacts upon health. And some of the benefits that HiA can support with are involving people affected by decisions in the process, just as I sort of was talking through there. And that helps to hopefully gain some buy-in, but also supports transparency of decision making as well. The process can also increase stakeholders' understanding of the factors which shape our health and cause health inequalities. And that's going back to making sure we've on the ground there is that broader understanding of what influences our health, and that we've got everyone on the same page in relation to that. There is also better awareness of how decisions affect health and communities, and it's very much an evidence-based process, and so using the data and evidence available to plan and inform decision making with the ultimate aim of improving health outcomes and greater equity in health. And one of the almost sort of byproducts of that process is that it can improve collaboration, partnership, working across sectors, and just being part of the process can help build those relationships and improve some of those understandings about other factors as well. So this slide just outlines the 6 stages of a health impact assessment process. It's not necessarily a linear process. You may kind of go back and forth between these, but it's what you may expect to find kind of as going through that process as a starting point. And the first step is screening, which is effectively just making a decision about whether you're going to undertake an HiA or not, and making that decision about progressing to do an assessment. And if that's the case, then you would move on to scoping, which is really focused on what does that then look like, what's involved, what so the geographical boundaries, what the timeframes, who's going to be involved, what stakeholders do we want to consider, and mapping out what that process is going to look like. We then move on to identification of impacts, and one of the key stages we recommend as part of this process, and kind of one of the starting points really within HiA, is holding a stakeholder workshop and bringing together different people with different views to understand what the potential health impacts might be of the local development plan or whatever policy it is you're looking at. The next stage is appraisal, and that then thinks about what different evidence we might need to be gathering in addition to sort of maybe answer some of the questions that have come out of the workshop, or what is our what gaps in information might there be, and what do we need to understand a bit more about some of those health pathways and sort of the consequences for different populations and what that might look like. That then moves on to developing some recommendations and actions for what we might want to change as part of the process, having gone through this. And finally, the monitoring to make sure that those actions are followed up and we're kind of looking to those longer term impacts. So just to spend a little bit more detail covering the stakeholder workshop that I just mentioned there. It's effectively a structured discussion to identify health using a checklist, and we've got it's just a health impact checklist. You can see a screenshot of there on the slide, which we can add the link to and will be shared. And that really provides a structured process to have a discussion as part of the workshop, and considering different population groups and health determinants as part of that. The process is not definitive in itself, but it often provides insights into how impacts arise. And in some cases, you might have a workshop and decide that's all you need to do. In other cases, depending on time and resource available and what comes out of that, maybe some of the key questions, then you may go on to do further evidence gathering and appraisal. In terms of who to involve in that process, it's useful to gather not necessarily as many people as possible, but you really want to get sort of broad and diverse perspectives as part of that process. So it's important to involve people who've been involved in developing the plan, people with any particular expert knowledge of relevant policies, people who are affected, so people sort of living within the community. You wouldn't necessarily involve them directly, but sort of specific interest groups, and also the third sector as well. So there's a range of different people you can involve in the process. And this slide just outlines the sort of different aspects that we would look at in a stakeholder workshop in relation to both the population groups and health determinants. And so the population group stage, we start off going through that quite systematically, and there's obviously a number of different groups within those subcategories to really kind of have the opportunity to consider each of the different population groups in turn to ensure that systematic process as part of the assessment. And obviously there won't be impacts for all of them, so some of those you'll just be kind of going through quite quickly. Others, there's a lot to consider. So if we start in terms of protected characteristics with age, for example, that effectively covers everyone in lots of different life stages. So usually a lot to talk about there. And by the time you've covered the population groups, you move on to health determinants, you may have actually covered quite a few of the things that come up already. So that section is maybe a bit more structured at a high level and looking at taking those determinants as groups. So this slide just highlights some of the range of impact assessments in use across Scotland. I think somebody alluded to that in the questions just before the comments in Menti. There obviously are a lot of assessments out there which do take time and an input to pull together. Some of those, as outlined on the left-hand side, are aligned with statutory duties and are things that have to be completed, whereas we know that health impact assessment is not, but it can really sort of support the good practice as part of the process of developing an LDP. And we've developed within our team a guide to impact assessments related to us in Scotland, which is on the screen there and may be of interest to provide a bit more information. So just briefly, this slide tries to illustrate how what we would cover within a stakeholder workshop links actually to a number of different impact assessments. So to kind of avoid it maybe being seen as an extra thing to do, what we would advocate for is undertaking a stakeholder workshop at the outset and actually using that to feed into lots of different elements of the relevant impact assessments that you might need to complete, or whether that also might be an integrated impact assessment. And we cover things aligned with Fair Scotland duty, quality impact assessment, and requirements of the public sector quality duty. Also, as I mentioned, consider age, which links into children's rights, the physical environment for strategic environmental impact assessment, and also remote and rural locations as well. And just to cover the overlap between strategic environmental assessment and HiA in a little bit more detail, because obviously there's kind of connections there in relation to health. The SEA is very much focused on human health, so it's kind of more thinking around those environmental conditions and pathways which impact upon our health, such as noise, air quality, traffic, and so on. And thinks about how they sort of test some of those significant effects within the plan. And as I outlined already, that's a statutory requirement. Health impact assessment has a much broader perspective of our health and looking at it from a population level. And so as I outlined, it's considering impacts across different population groups and the building blocks, and is really looking at actions to improve outcomes. And whilst it is non-statutory, it's recommended good practice referred to within the population health framework and also within NPF4 as a method of really kind of trying to use the opportunity to look at the potential health impacts of plans when developing an LDP. There is a scope to think it's kind of duplication. So in relation to avoiding that, it's really important to kind of basically look at these things early on and think about aligning the scope of the assessments and looking at what's been done within SEA and HiA and kind of seeing how they come together and can be cross-referenced and then sort of proportionate to be able to understand any differences and trade-offs. So when you're kind of doing that SEA part of the assessment, you might be looking at whether there's an increase in sort of poor air quality at all in relation to a specific development. And across the whole of the area, there might not be anything which is shown apart from that. But within a health impact assessment, it might come across that with specific populations located near to areas of growth, that actually there might be a reduction in air quality which impacts those specific populations. And that's not highlighting that the assessments are in conflict. It's more just kind of creating a greater depth of understanding and information to bring those together and provide a bit more information at that early stage to hopefully understand those potential impacts and be able to do some mitigation.
That's the final minute, Helen. Okay.
Oh goodness, right, okay. I can't see any time, so I've lost track of everything. In terms of integrated impact assessments, we're aware that lots of people are using these now, so I'll kind of let people look at the slides after that, but we have developed some recommendations for these, which are effectively around holding a workshop to look at populations and the wider determinants and involving public health staff within that. So in terms of options for considering an HiA of an LDP, it can really be that high level plan direction that's looking at those strategic level decisions. Another option is focusing down on specific policies and those that are related to more related to health, such as maybe housing or transport. Another opportunity is looking at specific places or areas where there's going to be additional growth and focusing down on those and how impacts might be different, or integrating within existing assessments, which is what Alison kind of talked about in terms of strengthening that health lens. So finally, just some quick suggestions in terms of getting started. It's really about kind of thinking what's different in the new LDP, what's going to change, and being able to then use that as a starting point to think, what do we want to look at in terms of an HiA? Considering different strategic planning choices, and some of those are listed, to kind of have that sense of what are some of those kind of key things and how do we want to consider them. And then just reiterating the point made earlier in terms of bringing together planning and public health colleagues and sort of having those discussions early or as soon as you can. And we do have health impact assessment leads in each of the NHS health boards that may be able to facilitate some of that if needed. Thank you.
Thank you, Irene. It's great to be here today. Thank you very much for the invitation. So just to introduce myself before I kick off with the presentation. So I am a principal public health practitioner within WIASU, which is the Wales Health Impact Assessment Support Unit, and we sit within Public Health Wales. And I've been with the team for about 18 months. I spent a long time before that working in Cardiff and Vale local public health team within the health board there, and I'll talk a little bit about that later. But I have a background in planning as well, so I'm also a qualified planner. So that's where I started my career in planning, and then over the years moved into public health, and now in the very fortunate position of being able to merge my two backgrounds and do the job that I do now. So I'm going to talk about how we use HiA particularly within planning and health in Wales. And as you've already heard, there's quite an expansion around other ways of bringing health into LDPs. But just a bit of context, just to kind of recap, I suppose, of what you've already been hearing. So that link between spatial planning and health started many years ago, drifted apart, and is now coming back together and being reflected, I suppose, within national policy UK-wide. But yeah, there's reflections there from the UK Parliament where it's really obvious, isn't it, where people live, the places where we live, have a substantial impact on our health and on our likelihood of developing preventable health conditions. But it's really understanding how that happens. How do we do that through planning and design? And recognizing that planning isn't going to solve all the issues. It's a key tool, but it isn't going to solve all the issues that we know we have in terms of public health, but it can certainly do a lot. So just give a bit of context about Wales in terms of our planning framework. So similar to Scotland, we've got a national planning policy framework, which is very much focused around health. That's our Future Wales plan, recognising that role of planning in creating healthy places. But our planning policy framework, PPW, really kind of spells it out, and it does weave it throughout that document, talking about how planning authorities have that role in developing and maintaining places to support healthy and active lifestyles across all ages and socioeconomic groups. But it goes beyond that as well. It's not just about healthy and active lifestyles, it's about all sorts of ways of embedding health and well-being through planning and design. And it also recognises the contribution that health impact assessment makes towards plan making in particular. So our policy levers, you're probably aware of our Wellbeing of Future Generations Wales Act 2015, and that really gives us that, I guess, understanding of how public bodies they have these duties under the 7 wellbeing goals, and that gives planners the role of thinking about well-being, you know, in terms of that guidance and that act, because it's something that all public bodies have to do. So it aligns quite well with the goals of the Wellbeing of Future Generations Act. But we also have the Public Health Wales Act of 2017, which is bringing in a duty to carry out HIAs under the regulations, which are going to come into force next April 2027. And that will be public bodies having to do HIAs on what they consider decisions of a strategic nature. So they're going to have to be doing HIAs. So as a team, we are currently very busy preparing for the implementation of those regulations with guidance and training, etc. But it's a really positive move, I think, by Welsh Government. And also we have the obviously some devolved policies, which enables us to take forward lots around planning and health. So HIA in planning in Wales, we use it both at the planning policy and the operational level. Generally, we're seeing HIAs undertaken as part of the local development plan process. So they're often undertaken, well, pretty much always undertaken as part of the integrated sustainability assessments that you've heard a little bit about. So HIAs are done frequently as part of that sort of integrated process. But many local authorities are now doing stakeholder or rapid HIAs, in addition to what their consultants generally are doing in terms of the integrated sustainability assessments. And that really adds that really important qualitative element of what we would call the lived experience. And as Helen was describing, that those insights from those key stakeholders who really understand the communities, the inequalities that are happening, how things might be affecting people differently in terms of planning policies. So it's an additional element that's really key in terms of HIA at a policy level. And we're often also seeing, the HIA is carried out at preferred strategy stage, the high level policies, but also then at detailed policy stage when the deposit plans are being developed. Kind of almost a sense check, I guess, of looking at those policies and how they're going to affect health and well-being. And we're also seeing them done, HIAs done at supplementary planning guidance level. So that can be done as a standalone HIA on an SPG, or you could do it on a planning brief. You can use HIA as a tool for all sorts of elements around planning. But the important thing is, as has been described, it's evidence-based. It's a tool that's been around a long, long time. It pulls together evidence from different sources, from data, from literature, from stakeholders. So it's quite a key tool to use in terms of developing evidence around planning and health. So what we're doing in Wales around, generally around connecting health and planning in Wales, and I'll come on to HIA in a bit more specifics in a case study in a second. But what we're seeing, as has been described as well in Scotland, is the local development plans that we're seeing very much a health and population needs focused vision and aims. So really recognising what are our key issues locally when a local development plan is being put together, where are inequalities, how are we needing to focus these, what are the issues, such as the obesity levels that we're seeing within the communities, the levels of mental health issues, that all of that is dealt with and addressed through local planning where it can be. We're seeing that focus quite clearly. Sometimes the local development plans are weaving health and all policies throughout. Some have a standalone health policy, but it's featuring in those LDPs somewhere. Health impact assessments, as I said, that are done on LDPs, but we're also seeing them brought into LDP policies as a requirement for major development. And as I'm sure you know, it's been happening in other areas quite a lot in terms of that requirement. I know many English authorities have that. It's not something we really had in Wales in terms of asking for LDP policies on things like residential developments and mixed use developments, but it's starting to happen. That requirement's coming in for HIAs. And supplementary planning guidance has been developed on health-related topics by various authorities as well. And then we've got much closer liaison happening in many areas in Wales between the local authorities and the local health boards. So in Wales, public health sits within the local health boards, it's still within the NHS, but we're seeing much greater connection between authorities and public health particularly, but also strategic planning in terms of provision of healthcare services. So they do things like responding to consultations around LDP and providing that evidence base that was mentioned a bit earlier in development of the LDP. And local health boards also respond to planning applications as a non-statutory consultee where it's appropriate for them to do so. And we in WIASU in Public Health Wales, we provide a lot of guidance, support and evidence obviously around HIA, but also wider than that. So we've just recently published a Planning Healthy Places guide, which really takes you through from the evidence base of why do we need to do this in terms of creating spaces that benefit our health, but the real nuance of that. So if you're providing a good space, what does that mean in terms of health outcomes? Take that right through to improving health and well-being. Where is that evidence base? Because there is a lot of it out there. So bringing that through into a space that will support planners to bring it into their policies. So in terms of what we're seeing working well in HIA in practice, we're seeing that in development plan process, it's giving that explicit regard to health inequalities, it strengthens partnerships, and it helps people understand each other's language, particularly between planning and health, because there is sometimes that disparity in understanding of what can you do in planning terms and where does health lie, and is it about health and well-being, or is it just healthcare? So that language is really important. Better consideration of health and well-being in land use policies and meeting the requirements of the Wellbeing of Future Generations Act. That's happening quite clearly. And then that additional element of the rapid participatory HIAs is really adding that qualitative element and those stakeholder insights. And every time I do a workshop, where I facilitate a workshop on HIAs to do with LDPs, you see people going, oh, I didn't realise that was connected to planning, and I didn't realise that was an issue for the local community. You know, it's really key to having that stakeholder engagement, and it's helping to shape the policies of the LDPs. We have a series of tools that we use, similar has been described earlier, that population groups and determinants, we take people through a tool to facilitate those sessions with them. And we also then can look at the assessment of local healthcare services as part of that process. So to give you a specific case study of how that's happened in practice, so in Cardiff, they're going through the process of adopting their LDP, hopefully later this year. It's currently at the inspection stage, but they did 2 rapid participatory stakeholder workshops as part of that process of developing the plan, one at preferred strategy stage and one at deposit plan stage. So preferred strategy was very much about the whole LDP and how health could be impacted by the policies within that at a high level, and thinking where are the key considerations of health, where are inequalities, what are population groups that we need to be considering. And that process was carried alongside the consultants who were doing the integrated sustainability appraisal assessment. So the stakeholder element was an additional bit to that. And then at the deposit plan stage, there was a consideration of the detailed policies and a bit of a sense check of were these policies meeting those needs that were identified through that process of doing the HIA. Was there anything specific that needed to change? And what we've seen, not just from the HIA, but ongoing partnership working in Cardiff, was that there was detailed background information produced as part of the LDP process, a background paper with all the evidence base in there around needs, recognition of those key local issues in terms of where the inequalities lay. Cardiff are bringing in the requirement for HIA for major development, which is new in their LDP. They've established an LDP reference group, which brings together the health board and the local authorities in Cardiff and the next door Vale of Glamorgan to look at where development is happening and to inform the provision of healthcare services. And really importantly, the updates to the deposit plan as a result of the HIA placed a greater emphasis on inclusive, child-friendly and gender-sensitive design because there was a lot of discussion and a lot of evidence gathered about the importance of the accessibility and the appropriateness of spaces for all ages and genders and cultures, because sometimes it can be quite narrowly focused in terms of who spaces are designed for. So there was a lot of recognition in that through the workshop and the process and the evidence gathering. And
That's
the changes
final
to the
minute,
deposit
Cheryl,
plan.
sorry.
Okay, that's okay.
Thanks.
And then detailed policies were brought into the plan around health and well-being and around food sustainability, so access to healthy food. That was an addition to the LDP. And a detailed policy around play and informal recreation. So this bit was additionally part of another policy, but it was brought out into its own policy because of the recognition of the importance of play and recreation for children in particular and how it impacts their health and well-being. So quite a lot of amendments were made, not substantial particularly, but lots that will make a difference in terms of how design comes forward from developers. So I won't go through this in detail because of the time, but basically the same thing happened in Bridgend in the replacement local development plans, a similar process. The HIA led to some amendments and some really key consideration of what those major health issues were in the local community and reflected that back through the local development plan, which has now been adopted. And Bridgend, as an authority, recognised the value of HIA, and they've used it for other things such as outdoor recreation supplementary planning guidance, which brought together a lot of key stakeholders to look at that SPG and think about how it might impact on different population groups and on inequalities. So I just wanted to finish on just a bit of a reflection really on some of the learning that we've had from not just Cardiff and Bridgend, but other areas around Wales. So the participatory elements of HIA are really important to bring together that qualitative information and the insights from those stakeholders and that lived experience. But HIAs can have other impacts as well, so they can help to make connections and new partnerships. They can help embed health and wellbeing in planning, but maintaining the relationships and having health and all policies approach is absolutely key. And I would say the relationship, particularly in Cardiff, where I worked for a long time, that was years and years of relationship building, particularly with the policy planners, to get to the point of having a really strong relationship. And we were meeting every 6 weeks between public health and planning to just kind of share what was going on and see how things were going, share new evidence, etc. So it's really important. It's really important to understand the opportunities and challenges for the provision of healthcare services. So that infrastructure, that's really difficult to understand, and it can shift and change. And it's really important to have those connections so that understanding can be gathered. HIAs do require local support and guidance, and that comes on to the potential gaps. So as I said, in Wales, our public health teams sit within our health boards and don't always have that skills, knowledge and capacity to engage with planning and health impact assessments, although that is changing a little bit in some authorities and health boards in Wales. The planners need the knowledge and skills to quality assure HIAs they get from developers, and developers also need to know what's being required from the authorities. So we're looking to help authorities have a bit more of a standardised approach and guidance to HIAs for development in Wales. Developers need to know where to get their data and evidence to support the HIAs. And finally, early engagement is absolutely crucial for HIAs for development and policy planning, because you need to do it at an early enough stage to make a difference. So thank you very much.
Where we are now, what can we hope for? A bit more information and support from Public Health Scotland. Can I pass over to yourself, Michelle Gillies, to give us that big question, to answer that big question? Here we go, over to you.
I'll do it in 3 minutes.
Great.
So just to say that we have a wide range of resources being developed that are available on Public Health Scotland's website. And this just signposts some of those resources. We've got a guide to health impact assessment, an introduction to health impact assessment, and a guide to health impact assessment. Someone had mentioned on the slides rapid HIA. We tend not to necessarily use that language in Scotland, and we tend to think of HIA as just being proportionate to the time and the available resource and the capacity that you've got, and also the window that you're trying to influence. So that gives you some guidance around how you can carry out HIA that is proportionate to that. The health impact checklist runs through our different population groups and determinants of health that we would consider in carrying out a health impact assessment. There's a bit of conversation about different types of impact assessment, and we've got a guide to impact assessment and related tools. So that picks up things like your place standard tool with different lenses. And that really shows the different types of impact assessment, that some of which are mandatory, some of which are currently optional, including health impact assessment, sadly, in Scotland, but we continue to advocate for mandatory health impact assessment in Scotland. But that's really helpful in allowing you to see how these different types of impact assessment can intersect, and potentially thinking about how you could use, say, a health impact assessment scope and stakeholder workshop to meet some of the requirements under some of those other impact assessments, like your EQIA or your Fairer Scotland duty. And then, because we recognise that more and more people were carrying out integrated impact assessments, HiAP, which is the network I'll speak about in a moment, got together and we produced some recommendations around the minimum consideration of health in the integrated impact assessment to help and guide people who've adopted that approach. Next slide, please. There's just a couple of slides. So, on our website, and the URLs here, we've got some evidence guides, some examples of completed health impact assessments that you can look at to see what we've done. We've got some explainer videos that colleagues from across Scotland have contributed to, and we're collecting case studies of completed HIAs at all scales. So from what colleagues might think of as a rapid HIA, we've just done a stakeholder workshop, due to full HIAs. And this is so that we can share examples of practice from across Scotland to help and support people who would like to adopt that approach. Next slide, please. And there's, of course, a range of other resources. So Cheryl's signposted some, and Mark's done a fantastic job of promoting the resources that colleagues in Wales and elsewhere have been producing. So the WIASU in Wales is a bit like our HiASU, the equivalent, and they've got a lot of tools and resources, again, that are relevant to colleagues working across Scotland. So do really encourage you to look on those resources. Obviously, the work that Improvement Service have done around shaping places for wellbeing. We've got the place and wellbeing outcomes and evidence briefings to support that, which really underpins those outcomes, indicators, and the place standard scope tool. And there's various lenses now available that can be used, climate lens, and a tool used with children to really support colleagues using that to understand their local places and then to help them develop plans. And the health impact assessment obviously can be used on the plans and policies that have been proposed to try and maximise opportunities for health and minimise potential harms. And next slide, please. And I mentioned HiAP. HiAP's a network that Margaret established. I'm not embarrassed her by saying how long it's been running, but I think it's 25 years this year, and it's really an interdisciplinary network where people who are interested in health impact assessment and health and all policies can get together, and we can share learning, share examples of good practice. The resources that I signposted earlier were co-produced with colleagues who participate in the HiAP network. So it's a really great opportunity to help and support us to develop resources that can inform and drive forward good practice in Scotland. So we really would welcome a broader membership. We welcome colleagues from planning, bringing their knowledge and expertise into that space. So that, again, we can ensure that the resources that we're producing and the examples that we're sharing of work across Scotland really do reflect the breadth of practice and the need that's out there. And the joining details are there if you would like to join. We've got an active Teams channel where people share information. We hold quarterly meetings, and in between we have shorter lunchtime learning sessions that colleagues can join. I think there may be one more slide.
Very quickly then, can we?
So
thank you.
If you want to reach out, please just reach out. Small but perfectly forum unit, and we're here to answer any questions. Please don't be shy. Please just reach out. We'd love to have a conversation.